The broadest description of population health management really is about looking at real-time data. So this is something that we've never been able to do before, because historically it's always been 2 or 3 months out of date, which is meaningless. So it's being able to look at real-time data for a population of patients, for example our frailty cohort that we've been using in North Dorset, and actually understanding what the data means. And that can then direct us to try and have a more proactive approach to healthcare. So for me, it's really about where we direct our resources and become preventative, as at the moment everything is really reactive, and we're sort of chasing our tails, trying to help people when they've fallen over rather than stopping them from falling over.
We look at all the information on the GP system. We look at how many admissions that patients had within the last year. If it's more than 2, then clearly we want to then be able to help support them so that then they don't go into hospital. Whether they've had lots of out-of-hour phone calls, that may be because they're lonely. It may not be for anything specific health needs, but it might be that they're lonely and they just want to talk to somebody. So then we then phone them at home and offer to carry out a home visit. Frailty is very complex, it's multidimensional, it's not just about physical needs, it's the elements of social and environmental. So we then go out and we're very fortunate in our role because we can spend an hour with that patient, and our first question is, what matters most to you? Because what matters most to us as a health professional may not be what matters to them. They may have swollen ankles, but actually that's not what they're interested in. They want to be able to cut the hedge. So how can we support them to cut the hedge?
This is a typical day for me. I'm reviewing a patient who I saw last week. She was registered as severe on the population health management list. When I saw her, I implemented some social prescribing. What mattered most to her was to stay at home with the support of her husband, who's registered as her main carer. I referred her husband to our Social Support Carers Association. He's now getting some support with regards to benefits, carers advice, and he's actually getting some respite from looking after his wife. I've also referred her to the meds management team, so they're looking into her polypharmacy and have implemented some medication changes. They've also introduced some blister packs, which will help her and her husband supervise the medication of her tablets. I've also referred her to Age Concern. They're going to be able to offer her some befriending so she's not feeling so socially isolated, and it will also provide some, again, additional respite care for her husband.
The patients we see really like to know that we are here and available for them to speak to. Clearly, for medical conditions, they like to see their GP, but they're very much aware that GPs only have a minute amount of time that they can actually talk to them. But having our hub contact number where they know they can phone up and say, I've got this issue today, please can you come and see me? And as I said, I can spend an hour with the patient and not feel guilty, because I know that it's a benefit to that patient to be able to talk to them and, well, more importantly, to listen, to find out what's going on in their life. And you learn so much when you've got that time.
Social prescribing to me has completely changed my approach to nursing. I've moved away from a medical model concentrating on a condition, but towards what matters most to the patient. By confirming what matters most to them, I can redirect my care and use social prescribing along with allied healthcare professionals and the community networks to actually enable that patient to achieve what matters most to them.